Okay. Uh, Good afternoon again, and I want of you just do the P-test. It is was to check yourself and that you have a bad information or knowledge about the pediatric CPB MASH, and maybe it's for me to to know that after learning how we can improve the knowledge about the pediatric CPB too.
So, can we start now? Can they start P-test now?
Yes.
Okay.
Maybe you can do it and maybe listen to our talk during waiting for. Ajahn An, I would like to know that what is present on your skin? It show my face or it does not show my face?
But
But I didn't see. I just see only the screen from my desktop. How?
what it is? Is it?
Actually, it should be that way.
I will send you my my photo. So you have okay.
Okay. Like this is better.
You want this one like yeah.
Eh? I don't know. After my my section, maybe I don't know. I will be tired or you will be tired. It's like we are talking, just both of us. Why students so quiet?
Because there's concentrate on the pre-test.
Just don't be so serious because it's not no it has no score. I will give you an answer after the post test, but the score is not related with your grade for sure. Just feel free to do it. Ajahn An, when will you go back?
Yes, maybe next summer. I mean the April after Easter break.
Oh, so long.
Yes, I have some time spent here to
But
do anything.
stay there is good too. It is so nice, or maybe lonely instead.
At Scotland, like
Yes.
I'm really serious about my PhD job, so is cannot think about each other. Like so,
Don't
yeah, I don't have no time to think.
don't travel so much.
Yeah, don't travel so much. Yes, I try to do that, but you know, the weather like Casey is there are
So cold.
4 seasons. No, there are 4 seasons in one day.
Okay, okay, it's possible.
Yeah.
But having chance, staying abroad is nice in life.
Yes, it's good. Yeah, sure.
Student would like to um, discuss during the section together. Maybe you can ask what you want. Maybe let me talk. I feel like I'm staying alone. And I plan to separate my listen into 2 parts, and maybe after done just a half of it, we can talk a little bit, or we can take a break.
Okay.
Because the topic is quite big, and maybe actually I didn't go deeply, just to let you know that when we want to do the pediatric case, what we should know and what we should think.
Mm-hmm. Yeah, yeah.
10 minutes is enough for 15 questions.
Sure. I think.
But you answer instead of your student. No one answer.
All right. If anyone who already done, please
Send me back, and maybe you can raise your hands up.
yeah, yes, you can raise your hands up. That we will know that you are already done. Good job.
It might take maybe longer than 3 hours, but I tried my best to complete it within that long.
It's up to you. It's up to you.
Maybe after 4 p.m. you will feel like you would like to vomit. โอ้ยอาจารย์อัน
ครับ
พี่กำลังคิดว่าตัวสไลด์เนี่ยมันน่าจะออกมา มันไม่ใช่อันนั้นแน่เลย มันเป็นคล้ายๆกับเอ้ยโอเคเดี๋ยวยังมีเวลา มันไม่ได้โชว์แบบคือนึกออกไหมอ๋อมันไม่ได้โชว์แบบ PowerPoint อะมันโชว์แบบแล้วก็PDF อย่างงั้นน่ะ
อ๋อ
เดี๋ยวนะ พี่จะทำยังไงไหมเนี่ย
อัน
เมื่อกี้เราก็มัวเม้าท์มอยแทนที่จะได้มาดู อ๋ออันนี้ได้อยู่ใช่ไหม
น่าจะใช่นะครับผมอันนี้ที่กันใช้ MacBook ใช่ไหมครับผมไม่เคยใช้เลย
ผมไม่ถนัด
ผมไม่ถ
เดี๋ยว
นั
นะ
ด
อ๋อโอเคเดี๋ยวขอดูแป๊บนึงขอลองแป๊บนึงโอเคได้อยู่พี่ละวุ่นวายกับไอ้ presentation เนี่ยคราวนั้นงานมาเก้ทีหนึ่งละแบบซ้อมแบบเขาก็เทสอย่างดีนะพอวันจริง PowerPoint เปิดไม่ได้เปิดได้เป็น PDF โอ้พี่อย่างเซ็งเลย Oh, no, nobody sent an answer yet. อันไอตัวสกรีนโชว์นี่มันยังขึ้นปกติไหม
ยังปกติอยู่ครับ
มันไม่มีรูปพี่ไปบังใช่ไหม
มีรูปพี่บางหน่อยนึงแต่ไม่เยอะครับ
เนี่ย
มีรูป
พี่สงสัยเนี่ยคือพี่ move อยู่เนี่ยตัวเองเห็นไหม
เห็นครับ
อ๋อเหรอเอ๊ะทำยังไงพี่ถึงจะย่อสกรีนตัวนี้ออกมาได้นะ
อันนี้ไม่เป็นครับ
เศร้าใจจังอืมบางทีเวลาสอนออนไลน์นะมันดูแบบเหมือนพูดอยู่คนเดียวอ่ะเราก็อยากจะเห็นอะไรบ้าง อันนี้พี่ว่ามันไม่ได้แบบเหมือนมันไม่ได้แชร์เป็นเป็นไฟล์ PowerPoint อ่ะมันแชร์เป็นเหมือนสกรีนแชร์มันก็เลยออกมาเหมือนแบบเห็นทุกอย่างบนสกรีนของพี่อ่ะ
อืม
ใช่ไหม
น่าจะใช่ครับ10 minutes
โอเคเอา anyone already done
Yes อาจารย์
can we start our
เริ่มได้เลยค่ะ
โอเคอ้าวแต่ว่า ยังไม่เห็นมีใครส่งอะไรมาเลย
กดเป็นยกมือกันนะคะอาจารย์
เอาเหรอโอเคไม่เป็นไรI will check it later okay today we gonna study about the paediatric cardiopulmonary bypass so I try to go so fast as I can and today the scope that we gonna talk today is about the challenging of the cardiopulmonary bypass, especially in infant or in the smallest baby, and equipment that we use for the pediatric case, which is I think is similar with the adult case. And the third is about the bypass plans. How do we plan during uh, when we do the pediatric and CPB management during the bypass, how do we do? The fifth, we will, I will talk a little bit about the myocardial protection. And the last one is the perfusionist role when we do in the real practice. First thing that we have to know in mind that the children are not little adult is, I mean, we can think that the baby is just the smaller adult because so many things different. Why the baby is more challenging than adults? Because we have to know that in after delivery, the baby has a higher metabolic rate than adult, higher oxygen consumption rate, and organs still immature, especially the main organ like heart, pulmonary, liver, and kidney. And the thermoregulation is impaired. The baby has less subcutaneous skin, so they lost the heat easily. And they also have a rapid change of a pH, lactic acid, and glucose level too. That makes all children, especially with the smallest baby, require higher folate per BSA, and the baby will use the wide variation of the folate more than adult. Like maybe we sometimes we use the folate only 2.4 cardiac index, and maybe sometimes we have to flow higher up to maybe 4.2. And the baby had a significant hemodilution because the hemodilution is unavoidable because the baby, like we focus on the smallest one, that like infant 2-3 kilogram, maybe they will have the blood volume about just only maybe 200-300 cc, but the pumping solution that we use is maybe even the same with the blood volume. That's will make the hemodilution is so huge. And the significant hemodilution is not dilute only the rest but still only dilute the hematocrit, but it means that it's dilute clotting factor and plasma protein as well. The acid-based strategy is different because especially when we do the deep hypothermic circulatory arrest, maybe we will talk about the bed acid-based strategy after. That's why it make the baby require the get attention to detail and ability to adapt to unexpected situation. Immature organ. For the first one, we operate the heart, so we should know the heart that it has a denser structure with the higher water and protein content per gram. And right ventricle and LV trigeminate are similar. After birth, you will know that the trigeminate of right ventricle and left ventricle is the similar trigeminate. But when they go up, the right ventricle will have to pump to the less pilotary, which is the pressure will be decreased after. So that's why the right ventricle does not need to tolerate with the high pressure compared with the left ventricle. So the left ventricle will trigger in the opposite way. The right ventricle will be more thinner. The fetal heart is the right dominant with the RV responsible for 65 of the cardiac index, and they have fewer myofibril in disorder pattern too. You will see the picture. In the gestation, the baby get the blood from their mother, and the blood go to the right atrium. 2/3 of the volume go to the right ventricle, or only 1/3 go to the left ventricle. And in the gestation, the lung does not work yet. So they survive with the shunt that's called ductus arteriosus. And after delivery, the lung, after first beat, the blood will go to the lung. And in the after birth, the blood volume still be so similar from the 2/3 to be 1.5 for both. And then the pressure, even the resistance of the pulmonary will be decreased, but at after birth, it's still high, and it will be falling to the like a normal pressure after at least two weeks. That's why it's related with the abnormalities such as tran artery of gas vessel, like the DTGA. We have to operate within 2 weeks because we are afraid about the falling of the resistance of the pulmonary artery. And they also have the immature sarcoplasmic reticulum and less T2 bull synthesis. The baby depend on extracellular for a cupping phase. Actually, in adult case, the contraction, have you ever heard that about the calcium release, calcium induced? Calcium from extracellular will come to trigger sarcoplasmic reticulum and release calcium inside the sarcoplasmic reticulum to the actin and myosin, and the cupping phase will happen. In the baby, the calcium inside the sarcoplasmic reticulum maybe is not full function. Maybe sarcoplasmic reticulum itself does not full function. It make the baby different from adult. The heart less compliance and less payload reserve. The heart they have a narrower range of function closer to the peak of a Frank-Starling curve. It means that the baby depend on the heart rate more than stroke volume because heart is small. When they need the higher, when they cry or they want more ATP, they have to increase the heart rate because stroke volume is it's limited to adapt. In the baby, we have to operate under the maximal adrenergic stimulation. It's like if we use higher dose than adult, it's normal. And the heart will be approached to the mature level about 6 to 9 years old. About the pulmonary, after birth, the number of alveoli present only maybe 10% of adult, and it will increase. The pulmonary will quite fragile and risky for pulmonary edema too. Pulmonary compliance is related to the increasing of lung water, but when the pulmonary compliance is decreased, it's reduced compliance and lung volume. When the water is inside, they will show the poor oxygenation and needs to increase the ventriculatory support too. The lung will be reached to mature level at 8 when they are 8 years. The kidney, after birth, they have a high renovascular resistance, and it will slowly develop up to 2 years. The effective of renal plasma flow and glomerular filtration rate after birth is still functionless, and it will reach to adult level at the age about 2. higher extracellular fluids in the neonates will make the difference, will make them difficult to mobilizing excessive fluid. I will talk about the water, the baby water after. You will see the picture how the water in the body of baby different from adult, and they say that the change of sodium concentration can be a result the fluid shift between extracellular fluid and intracellular fluids and make the baby get edema easily. Water influx to the intracellular space and make the cells swollen. It might result in cerebral edema, neurologic injury, and newborn with sodium less than 130. It will show that neurologic symptom too. About the liver, immature liver will impair the dark metabolism too. The clotting factor are not across the placenta, and we separate the clotting factor into two groups. The first group is the factor 5, factor 7, and factor 13 are at the same concentration with adult at birth, but the factor that related with the vitamin K, it's still impaired because the impaired hepatocyte. This factor is the factor factor 2, factor 7, factor 9, and factor 10, protein C and protein S, because at birth the baby has low vitamin K. And you should know that after birth, every baby get the vitamin K injection for the prevent the breeding incident, and the vitamin K will be increased after the baby was fed by breast milk, because the vitamin K will be synthesized by bacteria in the gut, and after birth the gut is so clean because they didn't eat anything yet. So after feed, the vitamin K will be synthesized, and maybe the our factor would be synthesis after. The function of enzymatic pathway will be fully active about 3 months after delivery. The baby is risk for hypoglycemia because they have less, how to say, glycogen storage, and hyperbilirubinemia because the baby has hemoglobin F, hemoglobin fetal, but the hemoglobin fetal is have a shorter life. They expire earlier than hemoglobin adult, and the liver will continue and mature at about 1 year of life. Equipment, it's not the different. It's not so different from adult. We use the Halang machine. We use the heater cooler system. We use oxygenator. Even the arterial filter nowadays we rarely use. We almost never use because only some company has the oxygenator without integrated arterial filter, and circuit tubing, cannula, cardioplegia system, and other accessory. This is the picture of our setting, the heater cooler. And what we have to know about the oxygenator for the pediatric, there are many sizes of the oxygenator because what we want is we want the less pumping, and but the smallest one has the smaller pumping has the smaller foliage as well. It's like this one, we can for only 0.8, Toromo, the smallest one can for 1.5 and 2.3 up to 4, 5, 7, and 8. In the different oxygenator, they need different pumping. So that's why when we use, we want the less pumping, but still achieve the maximum flow rate we want. Oxygenator that we want is like ideal oxygenator is the reduced surface area, because surface area, foreign surface area activate platelet aggregation. And smaller tubing connection, we can reduce the tubing we use in order to use less pumping. Coated with the biocompatible coating, it's good at the same with the reduce the surface area, because we want to the blood to expose the area as less as is possible. And distinctive heat exchange configuration. And the last one, integrated arterial line filtration. Now there is become general, because what we want to use it, we can cut off the arterial filter out to reduce the pumping. So as I said, the smallest but allowed to have a safe perfusion. The membrane, I think we already know, but just want to point you a little bit that they have two types. One type is the standard one, the one that we use, maybe FDA approved, or only maybe 6 hours for that oxygenator. But in the real practice, we can use is longer than that. It's like I used to use maybe 9 hour bypass time, but it still function well. And the second one is the ECMO membrane. It's made from the polymethylpentane. It's called plasma tight. It's tolerate with the with the water. It's we can use it longer, but the price is more expensive too. Arterial filter, as I said, is drought dead already, so we almost never use it. Tubing site, we have to think that so many size of the tubing, but you have to know in your mind before you set it up that in each part of the CPB circuit, it need the different of size, and it's different for nothing much for this one. You just remember for the 1/4 for the boost in or indirect way, you can use for maximum flow rate this one. And for the arterial line, maybe after pumping, we can use like a higher with the flow rate higher. And I'm afraid that I just want to make you clear that, okay, let me give you an example. Like if we want to flow for 2.5 liters per minute in for the baby, 4.5, you cannot use this one for the ragway. You have to use 3/8. But 2.5 for arterial line, you can use 1/4, because it's still available. It is still, it is still acceptable for this one. But if you use the siphon cavity drainage, you have to use the 3/8 for your drainage. But if you use the assist device, you still use the like a 1/4 for your drainage too. I think it's well explained. And the type of the tubing nowadays we use two type. One is the silicone. I usually use it in the indirect way, and the second one is the you can see it normally. We use the PVC, like it is the medical grade PVC. with the several sizes. And the range, we will put it in the circuit. You have to think how long do you use. The longer you use, it's a larger pumping you use too, but you cannot short it until you cannot move the circuit from the table, the patient table, because you have to let it long, uh, as long as it's still move the patient very well, because during the operation they might table down, table up so often. You have to think about that. Aortic cannula, what we use is we think about the larger internal lumen is the best, but for perfusionists we want a big one, but for surgeon they want a smaller one. So you have to discuss to them how big you will use. For the larger you use, if you have a higher flow capacity and prevent the excessive testing, shear force, and damage to bud element. But the narrow one is increased bud cell damage and several turbulent flow. But the surgeon would like to get the smaller one because it involves the field, the surgical field. You have to talk to them which side is proper with that baby and allow you to have a safety for. Usually in Thailand, we used I think we used two of it, but actually there are many. This one is like soft fold, and this one the tip is like straight tip. Pressure limitation. I mean pressure drop. We should limit it within 100 millimeter mercury. Venous cannula as is the same. The larger internal lumen is help to make you get the lower pressure drop and increase the flow capacity too. Too small, but the small of the cannula is different from the from the aortic cannula, because the venous will be determiner of the flow. You can you imagine, follow me, that if if your drainage is not so good and you have not enough volume for running your pump, you have to reduce the flow. That's why drainage is determine your flow rate too. You have to get enough drainage first in order to get the enough flow rate. If you put it too small, it might increase the ventricular wall tension too. There are so many tips: straight tip, angle, metal tip, and the pressure drop, it should be about 35 to 40 in case of you use the cavity drainage. Femoral cannula is rarely used in the routine open heart surgery. When we use it, we have to avoid insufficiency drainage, and it's difficult to cannulate too. The femoral cannula, sometimes we use in the ECMO case, but you have to imagine in the small baby, like newborn baby or infant, the head will be big, but the leg will be small, and the vessel, femoral artery or femoral vein, the cloy vessel will still small, but if we need to cannulate, like we need to do the ECMO, we have to focus on the neck vessel, which is quite big, or at least is bigger than femoral vessel for sure. when we choose the cannula, we have to think about the pressure drop. As I said, there will, when you get the cannula from the company, they will give you the how to say, application, or the chart of the pressure drop of each cannula that they sell. You have to check which size it allow how much for. And another accessory like suction and vent. The cardioplegia catheter, there are so many size. You have to talk with your surgeon how big, how small do you use. And we start with the bypass. Before everything we do, we have to get the patient information first, how big of the baby that we will do the bypass, how what is the patient weight, what is the patient height, and we calculate the foliage. Some in Chulalongkorn, we have the program to calculate the BSA, or even you can calculate yourself. For in general, if you have if you didn't calculate, you just use this formula, it's able to use too. But if you want to get the file adjust, you can calculate BSA, and you use the like a more proper folate. When we do the CPB, we use the cardiac index about, maybe in my practice, I use about 3, but we have so many things to monitor too, which I will talk later. But for the ECMO 4, you will see that we use the folate less than CPB, because when we do the CPB, it's like we take over the heart function. But with ECMO, we just support the heart, so heart still pumping, even it's less pumping until it cannot support. It cannot supply the blood itself. It needs the pumping, our pumping to support. But like we work together, heart work some and we support some. So the folate, it depend on heart function and depend on like a hemodynamic. The cannulation side, in routinely we cannulate ascending aorta and the right atrium for the case that we didn't open the heart chamber, and we cannulate bicameral for the case that we need to operate, like we need to open the heart, like we do ASD, VSD, or tetralogy or Fallot. We have to put two cannula like this. And for like biventricular, that we have to cannulate for size, for position. You can see that we will cannulate at the right atrium, and it is the light wet, and we return for at the pulmonary artery, and the left wet, the left ventricular assist device, we will drain from the apex, and we return the flow at the ascending aorta. This is what you have to remember, because what I teach, it just what we have to apply to our case. You have to know the abnormality at first. You have to know the procedure that the surgeon will collect that abnormality of the baby first, and you apply what I teach you together with your case. This is the neck cannulation. As I told you that with the small baby, if we want to do the ECMO, maybe we don't cannulate femoral, we will cannulate neck vessel, because we have to calculate the flow rate we want to use first, and then we have to check which cannula is proper with that flow, and we check how big of vessel that we will cannulate. It's able to insert that side or not. With the femoral cannulation, we have to check first. Normally in small baby, it's quite insufficient to cannulate to do the cannulation. But I used to ask the expert how big the baby that we can start to use the femoral cannulation. They said that about 15 kilogram, they might be able to think to cannulate at the femoral artery or femoral vein, but you have to check by ultrasound first that the vessel is big enough. If the vessel is big enough, so we can use the peripheral cannulation. For the venous cannulation, is not only SVC and IVC. Sometimes in the paediatric case or congenital disease, sometimes it shows that persistent left superior vena cava too, and this one is large until we cannot ignore it, and it's violent when it will it will drain the blood from the half of from the half of the baby head and return to the right atrium too. If we see the ref HVC with your case, you have to prepare 3 venous cannula. They said that while diameter of the size of the vessel up to 2 centimeter and the length of approximately 7 centimeter. The vessel obstruction it might mean that usually it does not obstruct, but when we do the surgery, if the maybe the surgeon did not see it, it will show the bleeding, and because some blood will go to the atrium as well. But you cannot you cannot suture it like you tie it. You suture just prevent the drainage, because it might make the vessel obstruction, and when it's obstruction, it can lead to brain swelling, or maybe neck, face, upper limb, which is not so good. And what we usually do is we cannulate it. Another one, we cannulate as another cannula. The cardiopedia, for the children nowadays, we use the Del Nido, we use the bad cardiopedia, we use Kisoroy, we use Custodial, which in each cardiopedia it had the benefit and it has advantage and disadvantage in the different way. So Del Nido is the single dose. Custodial is a single dose as well, but it is the intracellular, and all of this is the extracellular. The bad cardiopedia, many centers use the circuit set, adult circuit set, which is might make the total circuit pumping is larger than it should be. The pumping solution in our country, there are nothing much. We use the crystalloid solution as a pump circuit and clear air bubble. I use the mannitol 0.5 to 100 milligram per kilo, and I use the bicarb, sodium bicarb for the buffering. counteract with the acidosis of the acetate linker, which is pH about 6.5, 6.8. And I use albumin in the small baby because like kidney function is not so good. Oh sorry. I use the albumin, and the albumin can help to cause the circuit and help to decrease the platelet aggregation too. And I also use the heparin in our plumbing to prevent like sometimes they suck the breathing bud before the ACT achieve to the like a acceptable level before. Palming technique, if possible, we can do the clear palm technique first. If after calculated the hematocrit is acceptable, but if not, we add up the red blood cell and it's become the blood palm. The composition of the palming solution, and I would like to show you a little bit that human plasma, it has is contain like this oncotic pressure or osmolality is about 280 to 300. pH is normal, but what we use in our country is the acetate linker or aceta. It's a little bit lower in the osmolality. But in the US, they use the plasma-like, which is quite similar with the human plasma, and it's called balance solution. But this one is called crystalloid. It is crystalloid as well. But this one osmolality is better than what we use in our country. And this one is the sterlofundin. It is the balance solution as well. It's available in our country, but like not favorable because not many technician or perfusionists using it. And this one is the colloid solution. I will talk about it later. Maybe we can say that it's not totally bad, but it's not totally good as well. Clear palm, when we use clear palm, we will use it with the high hematocrit, and when we get the acceptable hematocrit after hemodilution, we have to calculate first. And with the case that show with the severe cyanotic or blue, because the hematocrit will be high, and the like an older pediatric and small adult case, which I expect that the blood volume will be a lot larger compared with the pumping solution. And blood pumping we usually use in the small babies such as neonate and infant, because however when we try to reduce the pumping solution, it's still large until the ratio between blood volume and circuit pumping is still the same ratio or maybe bigger than the baby volume. And the case that after calculated still get unacceptable expected hematocrit after hemodilution. This one can help. If we decide to use the clear palm, we can apply this technique together. First is an empty venous line. We can clamp and we drain the volume inside the tubing, or even you can drain total venous line and you apply the negative pressure a little bit. But they suggest to do that with the not like a so small baby. It's in my experience, I would suggest if you want to do that, maybe about more than 10 kilo or something, it should be less harmful. And we can do the retrograde arterial bud such as this one. This is the old picture. It might take a little bit longer as expect because I try to take the picture, but I forget to open the line. So we will see that we wait for bud running for several seconds. This line. It after connect the arterial line with the aortic cannula already, we can drain the blood from the heart, and we can take the volume out this like this. The reason we do this just for decrease our pumping, but you have to think that you can do this technique when the hemodynamic is still stable. You have to talk to your anesthesiologist that you're gonna do that. For the last one is the assisted venous drainage. Actually, we have the standard venous drainage with the cavity siphon. Routinely, we use that. But if you want to do the clear palm and you want to decrease your pumping solution, you can apply the assist venous drainage. So augmented venous drainage return there are three types. First one is the vacuum assist device. It's the machine to create the negative pressure. We connect the tubing inside the hard tail of the oxygenator, and we suck the pressure out, let the cardiotomy reservoir is negative pressure. It will suck the volume from the venous side. And the second one is the lower palm assist venous drainage, which I think is quite harmful to use, because if you want to use it, you have to monitor the venous negative pressure, which is quite difficult to do. And the last one is the kinetic assist venous drainage, which I have seen it in abroad, but in our country maybe not. I don't think any center in our country will do that, because it has to pay for the centrifugal pump. It costs maybe a little bit, maybe not a little bit. It's about maybe 5,000 to 7,000. But it's quite safe because it's payload sensitive. It's not harmful. And they suggest to use with the patient more than 40 kilogram BSA more than 1.27. The negative pressure is the same with the other assist device we use in the CPB case, with the negative pressure less than -40. Another technique is the circuit miniaturization. What we can do this is, first we use the integrated oxygenator. We cut off the volume that will contain in the arterial filter out. So we use the small tubing, as small as we can, like the arterial line. In the smallest baby, maybe we can use up to maybe lower to 316, and short the line as possible. The A line smallest we can use the 316. The venous line is still be maybe we have to think about the glutenase. We use the 1/4 and the boost in this way. We can use the smallet as a 1/4. If you do this spec, you will get the palming about maybe 200, which is very small already. 180 to 200, it's small already. But this in this testing, we didn't add up the volume together with the hemoconcentrator, so have to avoid another water that will suck from the field too. If you use the bud prime for the baby, you have to think about the how fresh of the packed red cell you will get. In my center, the surgeon will try to order packed red cell less than 3 days, the age less than 3 days. It will be so fresh, but in general, the fresh bud should be less than 7 to 10 days. Why? The reason is if we get the old packed cell, as we know, the packed cell has 121 age, and we don't know that which one is complete 120. If we collect the blood long time, some red cell will expire, and the packed red cell will contain with the lactate, potassium, and acidosis, which is not so good when we bring it to use in our priming. How to determine how much we have to, if we have to add up our, the packed cell or not, we have to calculate first. What we how to calculate is we use the blood volume of the baby multiplied by hematocrit at first, and then we divide by the patient blood volume plus with the circuit pumping that we use in that case. It depends on the case. It depends on how big the oxygenator, how long of the tubing you use. If you calculate after I mean, you will get post-hemodilutional hematocrit, and post-hemodilutional hematocrit is acceptable. You have to have in your mind that how much hematocrit in each side of the baby, each case of the baby that you expect to get. If it's lower than the expected hematocrit you want, you have to add up the packed cell in your circuit. How much you have to add is calculate followed by this formula. You get my slide. You can practice calculate it later. This is the protocol. Actually, I can tell you that no protocol for add up or the how much of the hematocrit in each case. Yes, even in my center, I try to follow by the protocol from Boston Children, and sometimes when I decide to how much I want, I discuss with my anesthesiologist that is okay with this case, or sometimes I discuss with my surgeon that okay, in the neonate, this high is okay with our patient. You have to talk, you have to discuss with your team how much you want, but this is the general number that you can bring to get or bring this number to discuss with your team. You will see that in the neonate we keep pretty high, even during bypass or before weaning of bypass too. Maybe this one didn't contain in the previous slide. I just add up last night. And you have to know that if you want to calculate the formula I talked about in the previous slide, you have to know how much the blood volume of the patient. You have to think that smaller, it has a higher milliliter per kilo of the blood volume too. It is the bad information. It is the bad information that you have to remember to use for calculating. How to manage our bypass? We start with the priming solution. At first, we have to use the crystalloid solution to clear the bubble. Crystalloid solution, at long time ago, we used the normal saline, but it's a hyperkalemic state and it's associated with the acute kidney injury. So nowadays, we use the one that more physiologic, like plasma-like and lactate linker. Now we still use the lactate linker in our country, but plasma-like, it how to say, it's common use in the US, but in our country we don't have the plasma-like. But all of this is still called like crystalloid solution, and the major drawback of the crystalloid solution is lack of oncotic activity, and it's result in the edema easily. Another one is the colloid priming solution, which has two types that there are. One is albumin concentration, and the second one is the synthesis colloid solution. Talk about the albumin first. Our albumin that we use is the human albumin. It helps to decrease the inflammatory response because when we use it, it can cause the circuits, make the circuits more smoother, and reduce the platelet aggregation, reduce the activating of the inflammatory mediator, and it's counteract with the decreasing of the colloid oncotic pressure too. There is the study in 2016. They compare 10 cc per kilo of albumin and 20 cc per kilo with the hemohair, or this is the colloid. And the last group is the only lactate linker only. It shows that in the albumin group, it shows higher post-operative platelet count and maybe colloid oncotic pressure. This is quite sure. And they said that lower post-operative bleeding, but requirements, extubating time, ICU, length of stay, and discharge time, it's still not different. So maybe they said in the some small dose, like less than 30 cc per kilo, it's still okay. Maybe we can use it, but if larger dose, it might related with the problem. And the synthetic colloid solution, which in our country we use the Woluwen. There is a study in the 2015 that they suggest to use the like colloid 6% of hemohair in the priming. They said like it's superior than albumin in the children, which maybe for myself I just confused that because many study in the adult, it show that significant renal dysfunction. It's like related with the significant renal dysfunction and coagulopathy until the FDA in the US they has placed the box warning to the hemohair solution that caution against their use in the critical ill adult, in the patient with the renal dysfunction, in the patient with the coagulopathy, and in the patient under open heart surgery as well. It shows that like maybe if the patient has to be to operate in the open heart surgery, they didn't suggest to use the colloid, the like hemohair. I okay, another a half hour. Okay, with the hemodilution, the baby we concerned a lot about the hemodilution because the dilution of the hematokit lead to reduce the oxygen content in the blood, but we still think that we have to, when it's to hemodilution, we need to add up the red cell because it, how to say, because it has so possible to to add up the packed red cell, because if we look at the ratio of the neonate blood volume and the CPB circuit volume, it will be it's a huge ratio. The neonate, as I said, like 2-3 kilogram, they contain the blood volume just only about maybe 250 to 300. It's larger in the bigger baby, maybe like the baby 8 kilogram, they will have like more larger volume. You have to think that the blood volume of each case and the pumping of the oxygenator of the CPB circuit you use, how it's different, and if after we mix it together, how low the hematokrit will be present. So if it's too much hemodilution, we try to avoid that by add up the red blood cell instead of the crystalloid. The needs of red blood cell that we put it in our circuit, it's just to maintain adequate hematokrit during the CPB, because as we know at first that the baby has a higher metabolic rate too. And I talk a little bit about the red blood cell. We have the nowadays we almost never use the only pure red blood cell. I don't know how to call it. Just the type of the red blood cell that we get. It 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 has the leukocyte poor packed red cell, and it has the low leukocyte depleted packed red cell. But the leukocyte depleted, as it said, it will be a lot expensive than leukocyte poor packed red cell. But leukocyte depleted, it means that it filter leukocyte better than leukocyte poor. So because the leukocyte, the residual leukocyte in the packed red cell is involved with the maybe problem after. The problem after we add up the packed red cell, we add the packed red cell in the circuit in order to have a higher the oxygen carrier, but we also add up the transfusion reaction too. We also add up the transmission of the blood-borne disease, which is possible even they try to limited it by the blood bank, but it's still it's still it's still left. And the red cells also have interleukin activating of the interleukin 8, secretory phospholipase A2, and cytokine generation. This is will create the problem because it will make increasing pulmonary capillary permeability, which make the patient has the like ARDS or respiratory problem after the CPB, and it will make the baby need ventilatory support longer. About the hemodilution effect, body water is the issue that we have to pay attention it. You have to know at first that the neonate and adult is different in the water. Total body water in the neonate is about 80%, but in adult it's about 60%. And all of the water, it will be in the extracellular part, like maybe in the vessel and in the interstitial. This is the inside the cellular is less than adult, but extracellular is a lot than adult. So, but totally, the total body water is a lot. It's larger than adult. So it make the baby has a water movement more than adult too. That's why the baby is get edema easily. This is the picture. Maybe I think it in general is not it is not the number in the baby, but I get it from like maybe it might be the number in adult, but you can compare that if in adult it is this number, in the baby it will be maybe more serious. This is the arterial side, like arterial vessel. What we have to know about the hemodilution, about the water movement, it's related with the two pressure, which is the hydrostatic pressure and oncotic pressure. Hydrostatic pressure is the pressure that will bring the water out of the vessel to the interstitial cell, and the osmotic pressure is the pressure that brings the water from the interstitial cell to the vessel. In the arterial side, the hydrostatic pressure is higher than osmotic pressure, so net filtration is about 16. So the water, the volume will still left in the interstitial cell more than come back to the vessel. But in the venous side, the hydrostatic pressure is lower than osmotic pressure. It means that in the venous side, the water will come back to the vessel, but compared with the net filtration for both sides, this is 16, this is -7. So the water will still be in the interstitial cell more than come back to the vessel. And you will know that the less of volume will be eliminated or delivered by duct system. This is you have to think that if you let the baby, if you let the water of the baby shift from the vessel to the interstitial cell, the baby will get edema easily because it takes time. It doesn't mean that maybe when we make the patient more hemodilution and after we try to make it concentrate and the situation will be come back to normal easily. No, it does not happen that way. Maybe the edema, the baby that get edema is take maybe 1 day or a couple of days to bring back to like a normal situation. This is what we have to concern in the baby. And this is the the paper that study about the effect of the hematokit on the cerebral microcirculation and tissue oxygenation during deep hypothermic circulatory arrest. They compare three groups, hematokit 10%, 20%, and 30%, measure both macro hemodynamic and microcirculation. It show in the three method. First is they focus on the mean arterial pressure. It showed that it was significant less relative to the, like maybe in the hematokit 30, in the group of 30% hematokit will show like maybe better mean arterial blood pressure, and tissue oxygenation will be significant less in the group of hematokit 10%. And the number of lowering leukocyte, it will be rested in the group of hematokit lowered, the hematokit 10%. They conclude that the study show that the superiority of the higher hematokit group is mean that the group of 30% hematokit relative to the lower hematokit value for the cerebral tissue oxygenation during the cardiac operation, including when they do in the deep hypothermic circulatory arrest. Talk about the fluid management. Actually, I will mention about what we have to mention as a perfusionist. We have to mention about the fluids during bypass, but we have to see as a big picture. When the patient come to the hospital pre-operative period, it might involve with the cardiologist or maybe a resident or the surgeon or nurses in the ward, that we have to know first that the patient came with the severe chronic heart failure or not. If the patient came with the chronic heart failure, the heart will be big and maybe blood volume that come to the pump will be larger a little bit or a little bit larger, and maybe they have to stop feeding, like a how to say no I forget it, just like don't eat. They have to patient will be dehydrated or during the fasting. They don't let the patient eat anything before operation. I forget the word. And this one will make the baby dehydration. And the dehydration, how the dehydration is related with us, because maybe when we see the hematokrit that high, we might think that, oh, the baby has a very high hematokrit. Now maybe in our pumping we don't need to add, we don't need to do the blood pump, but actually maybe what blood volume of the baby will be smaller because the baby has dehydration too. During induction, anesthesiologist will help us to help the patient, help the baby, not maybe not help us. They have to restrict the IV load too. In the very small baby, maybe they can limit it just only for 50 cc for the IV load. But in some case, some anesthesiologists, they don't mind about the IV fluid. Maybe they do as maybe adult case. It will the fluid will come to the baby so much, and we have to think about that. Maybe patient get the hemodilution even they didn't get they didn't get the bypass yet. It is what we have to concern too. And about us, the perfusionists, we what we involve with the fluid management is our pumping. Our pumping as I said before, we should try to restrict, I mean, use the as low as we can we can do. And about the cardiopedia volume, nowadays we didn't have the set that designed for the pediatric case, but I try to create with the company that the circuit that I will use, the cardiopedia set that I will use. It should be proper with the size of the baby. It should not involve so much. It should not carry a lot of volume, because it might make total circuit it super big, and maybe patient will get super hemodilution. About the surgeons, during the surgery, sometimes surgeon they wash their hands to suture to tie the suture, and some anesthesiologist will put the water in the field, in the surgical field, and they suck it come back to the pump. It will make the our circuit will be more hemodilution as well. And the last part is the ICU part, which is actually maybe our professional will be done the job after this. But in the ICU, maybe if the patient keep uh, continue breathing, then might need to give the patient for its resuscitation, or even some case that have kidney failure after. It might magnify edema formation. All of this is will determine patient edema or not. So it is what we have to think how to manage the fluid for the baby. Total issue for fluid management is the we basically starting with the minimize the circuits, as I said before, and we can do the retogate autologous pumping or retogate arterial blood pump. The third, we can do the vacuum assist venous drainage, and the fourth is the hemofiltration, which I'm gonna talk later. And the last one is the basal waste. So this one is mean that we use the auto transfusion or auto transfusion machine. The hemofiltration, we can apply it for three period of our CPB time. First one is we can use is P bypass. It's called that P bypass ultrafiltration. In this part, we can use when we do the blood pumping, because as I said before, with the old blood that maybe some center or some country they cannot find like a fresh blood, and they have to use packlet cell they have, which is maybe it might contain higher lactate, it might contain potassium, and the pH is it's acidosis. So they try to adapt, I mean adjust the pH of the blood pump as like they filter out, they filter the potassium out, they filter the lactate out, they adjust the pumping in order to get the proper pumping for before starting bypass. And the second part is we use it during our bypass when we have a lot of volume and we have less hematokit. We can do the conventional ultrafiltration. We filter the water out, and some waste will be filtered out as well. This how to say, this method we call like we filter out as a convection. with the hemofiltration, there are two types. There are two how to say two strategy. First is the convection, and the second is the diffusion. The convection is the we bring the bath with the pressure, and the water that come out will come out with the waste. But the diffusion, we will use the transfuse, dialysis, flow opposite way of the blood flow, and we don't use the high flow, but we let it pass, and the different concentration will shift the waste from to the opposite way, opposite part. But for this one, for what I mentioned, I mentioned about the convection first, like when the water out, the waste will follow. When the waste will go out with the water, and the zero balance at dilutional ultrafiltration is will apply when the volume in the reservoir is not so much, but we still want to filter out the waste, so we dilute the crystalloid or volume in the reservoir, and we try to filter out to to reduce the potassium or reduce the lactase. And the post bypass, after we stop CPB, and in the small baby, in the body, they have limited space to give everything, like pellet, FFP, or even some more packed cell. But if we stop bypass with maybe not so high hematocrit or quite low hematocrit, which is not enough for like perfume for the all organ, they suggest to use the modified ultrafiltration, which is we draw the water out of the patient body, and we filter the water out, and we return the more concentrated blood to the baby. But in this case, in this technique, you have to think, you have to see the hemodynamic together. If the hemodynamic is not so stable, maybe it's really difficult to do modified ultrafiltration, and you have to let your surgeon and your anesthesiologist know as well. They will keep the aortic cannula and venous cannula still. So with the modified ultrafiltration, I suggest you to use the rate, the flow rate, about 10 to 30 cc per kilo, and the range of 100 to 350 cc per min. BSA, some center they apply the MAF, the modified ultrafiltration, even with the adult case, but I don't know, maybe they have a paper that it show the beneficial of the modified ultrafiltration even in the adult case. You have to maybe you have to read some paper more. I'm not sure, but for the baby, they suggest to use because the vessel, the capacity in the vessel of the baby is limited. So when we use the MAF, we result is better. We reduce the water and reduce the edema in the small baby. BSA that they suggest to use is the BSA less than 0.7, and if the baby hematocrit is less than 24, we can apply the negative pressure as well, but maybe if we choose the hemoconcentrator, it's the one that has like a less transmembrane pressure. I mean, lower transmembrane pressure, the volume will go out, will filter out easier. So maybe we don't need to apply the vacuum assist device. And the commonly require about 7 to 15 minutes after bypass. The last one about the fluid management is some center they use the auto transfusion to collect every single drop of the patient blood. So if you want to use the auto transfusion device, you have for the for using it worthwhile, you should start to use it since after you cut the skin and maybe you saw some bleeding, you suck that blood to the cell saver. So you don't need to use the wall suction. You collect the blood from the surgical bleeding since you didn't start the heparin yet. And when heparin come in the patient, you use the CPB machine, and after you collect the heparin by the protamine, you can suck the breathing the breathing back to the cell saver, and maybe in in the volume that left in the oxygenator, you can collect it and you can centrifugal it, concentrate it, and give it back to your anesthesiologist. I think it's about 1.5. Do you want to take a break a little bit?
Okay ค่ะ
And go to the toilet. You can eat, drink some water, and maybe we can come back. 5 minutes is okay. Maybe you will get a brain edema already.
โอเคค่ะ โอเคค่ะอาจารย์ thank you ค่ะ
Just let me know when you come back, okay?
ได้เลยค่ะ
อาจารย์อ่านยังอยู่ไหมเนี่ย
อยู่ครับ
อาจารย์อาจารย์อ่านเงียบเลยอ่ะ พี่รู้สึกเหมือนพี่อยู่คนเดียว แต่พี่กำลังคิดว่าเดี๋ยวพี่จะส่งข้อสอบเก่าพี่อ่ะให้อาจารย์อ่านแล้วอาจารย์อ่านก็ไปปรับแต่งเอาใหม่นะพี่รู้สึกพี่ยุ่งมากเลย
ได้ครับขอบ
ตอนแร
คุ
ก
ณ
ว่า
ค
จะ
รับ
ออกเองไม่ออกแล้ว
อาจารย์ต่อเลยก็ได้ค่ะ
มา okay. We talk about the blood pressure management. The blood pressure is different from, I mean, we cannot think that when you do the CPB for adult case, you might expect that the pressure it should be like a more than 50, 60, 70. It's good for the patient, but in the baby, you have to keep in mind that small baby, especially with the neonate, newborn, or even infant, they will have a mean arterial blood pressure is lower. I mean, after we start bypass and during the case, if the blood pressure is about maybe 40, 45, it should be okay. You don't need to think that, okay, you have to reach your mean arterial blood pressure up to maybe 60 for the smaller baby. For the small baby, it's kind of be like maybe too high for the baby, because after birth, the I'm not sure, but as I have read before, it's like maybe the baby has some maybe vasodilator. It's available in their circulation, and it's make the baby has a lower blood pressure than adult. About the oxygenation strategy, we separate. We mentioned about the oxygen, and then we mention about the CO2 later. About the oxygen, it is the oxygenation strategy. They have two strategy. First one is the normoxic strategy. We will keep the PaO2 about 100 to 100 millimeter per curie, and the second is the hyperoxic strategy, that is keeping the PaO2 about 300 to 700 millimeter per curie. The oxygen, we will mention about the PaO2. We usually know when you sit in the behind the heart lung machine that, okay, how much we want to get the PaO2 during the CPB. We have to understand, we have to know first that oxygen delivery is the cardiac output multiplied by oxygen content, and the oxygen content is the formula is follow this formula. The low oxygen content in the how to say normal physiology. If the cardiac content decreased, it will activate to increase the cardiac output. Maybe our heart rate will be activated to beat faster. And if the oxygen content is decreased and cardiac output is decreased as well, like maybe pumping is not so good, the body will compensate to increase the oxygen extraction. You have to know that the oxygen extraction is related with the V naught oxygen saturation. Is the oxygen extraction and oxygen and V naught oxygen saturation combined together, it will be equal with 100%. I will talk about it after this slide. This graph will show you that the blue one is the anaerobic metabolism, and the red one is the anaerobic metabolism. This is the oxygen delivery. If the oxygen delivery is still enough for the body, it will the body will use it as a will function as a aerobic metabolism. But when it fall to this point, which is called the critical point, it means that oxygen delivery is lower until oxygen is not enough to function as a metabolic metabolism. It will change to create the ATP by an aerobic metabolism, which is not so good. Maybe this one, the oxygen saturate we not oxygen saturation will drop until, I'm not sure, in the paper they say like many number, but it's about 50, 55 something. It means that they extract oxygen much more, but they up to this point they cannot extract oxygen more than that, and they have the body has to change to the anaerobic metabolism. This become like the choke point, which is not so good if it remain in this situation for a very long time. All organ will be damaged. Talk about the oxygen transport to the individual cell. Each cell, we point at every single cell how to get the oxygen transport. The oxygen transport is related with the four how to say, four things. First one is when the cell will get the oxygen well, if the transportation, the speed of delivery is well, like a pumping good, it come fast, and when the pumping is good, the oxygen will carry faster and it go to the cell faster too. The second point is the oxygen dissociation curve. Even they carry a lot of oxygen, but the oxygen dissociation curve is make the oxygen release difficult. The oxygen will be released to the cell harder. So you have to know that oxygen dissociation curve shift right, shift left with by any condition like a temperature, CO2 or pH. It's related with the oxygen dissociation curve. And the third one is the distance, like this distance of each cell. It does not mean that every cell stay near the capillary vessel, because you will see from this picture, this cell is very near with the capillary, so it take a short distance to diffuse the oxygen from hemoglobin to the cell. But this cell is stay so far, so the distance is longer, so it's harder to get. But in the normal physiology, it can get enough oxygen even it stays so far. But it depends on the because it depends on the distance. So if we make the patient get edema, it means that the water stay in the interstitial larger. The distancing will be farther, right? We will be more distant, so it's harder to get the oxygen from the capillary vessel. And the last one is the cell itself. If the cell is like swollen, it's gonna die, and it does not utilize oxygen itself, so they cannot use the oxygen as well. How much PaO2 is good? Maybe no one can say that how much should we how much should we give the PaO2 during bypass. Someone say that okay, maybe 150 is good. Someone say that even we open 100% of PaO2 and get the FiO2, and we get the maybe 500 or 700 PaO2, it's okay. What I mean is for like just only CPB, not including ECMO, because ECMO it take very long time. It take maybe a week, maybe couple week. It's I don't mention about that. I mention only the CBP. So this is the survey from 2017. They survey in the US with the big center that can perform the Norwood operation. It showed that the range of FiO2 that they use is from 0.21 to 1. Top four choice was 0.21. Do you know this 21 is came from? Is from like we breathe in the maybe normal air, in the room air. It's the air that we take a breath. It's 21% of oxygen. But some center they use 100%. Like we give the maybe oxygen from the oxygen tank. Even in Boston, they use 1%, 100% as well. But it shows in this survey that the target FaO2 they used the most two popular range is about 121 to 200, and the second one is 201 to 300. They use maybe at the same similar percent. And about the selective syllable perfusion, they use similar with the maybe main CPB. They use 201 to 300 and maybe 121 to 200 as well. So just give you an idea. But maybe I didn't say that now you should do this, you should do that. But you have to you have to think. Someone said that we put too much oxygen. It's like we keep maybe FiO2 or PaO2 about maybe 500. It's a lot more than normal. Like in normal rate, I mean, the patient in the ICU, maybe they keep only maybe one, a little bit more than 100. But why we have to keep it too much? But during the CPB, maybe they consume the oxygen in different period. Like when we start bypass, we drop the temperature, metabolic rate will be lower. But during the rewarming, maybe metabolic rate will be back to be higher, and maybe they consume oxygen much more. You have to think about in each period of your CPB, you how much you will manage your PaO2, and how to say that we perfuse in the adequate perfusion. We have to monitoring. We have to monitor systemic perfusion, and we have to monitor regional perfusion. The systemic perfusion is mean that total organ is okay, but regional perfusion is mean that organ that we mention is okay. Systemic perfusion, we will see it from the cardiac index we use, like maybe in general adult case, we might perfuse about maybe 2.6 to 3 cardiac index. But in the baby, maybe we have to use a higher cardiac index, because in the some small baby, we need to delivery more, because the baby has a higher metabolic rate. But how do we know? Because if we have to know in mind, and what it can prove is the mixed oxygen saturation. It will show you that the oxygen left from after delivery, after organ use the oxygen, how much is left. It will show you more. It will show you faster. The second one is the mean arterial pressure. As I said, we have to know too how high is proper in each side of the baby. It doesn't mean that we will use the same number, like maybe 60. We have to keep everybody, every baby at the mean arterial pressure 60. No, it should not be that way. It should be, okay, this small, this high is proper. But if the baby is older, maybe this high is proper. You have to know the range in each side of the baby. And systemic venous oxygen saturation, as I said, is show that when we transfuse, when we deliver oxygen to the cell, to every organs, the set arterial oxygen, we expect that it should be 100%. But when it passed to the cell use the oxygen, and it come back to the venous side, which we call systemic venous oxygen saturation. It's after use oxygen. It's after cell consume oxygen already, and then the normal value, it should be about maybe 65 to 75%. If it's less than that, there are 2 points. One is first one is we delivery not enough. The second one is maybe we delivery not enough, and I forget it. Okay, we'll talk about it. I have this slide in after too. I will focus it at that one. And urine output. If in the baby, we will see the urine output. Our urine output will determine the perfusion in the baby better than adult, because every organ will be so clean. We don't need to worry about the maybe calcification in the brain or something, because we expect that vessel is so clean. If urine output is good, we kind of expect that every organ will get the good perfusion too. And acid-base status, it will we will focus on the lactate. Lactate will show, as I said, if the cell will use the aerobic metabolism, lactate won't rise up. But if the cell change to use the anaerobic metabolism, the lactate will be byproduct of that anaerobic metabolism too. It will help us to check that, okay, the perfusion is maybe not proper, but the lactate is quite delay to show because it happened already maybe many minutes, maybe a half hour, 1 hour, and then we will see later that lactate will be high up. It's not the same with the venous systemic venous oxygen saturation. If it's low, maybe it show and we can see it faster than acid-based acid-based status abnormality. Regional perfusion is mean that if you focus on each organ, like maybe brain, when we do the circulatory arrest and we want to check, they put the ACP, they put the selective cerebral perfusion, and we want to know that brain perfusion is still good. We put the near infrared spectroscopy, and this is a measure of brain activity. Jugular bulb saturation, maybe in our country they don't use it so much, as the same as transcranial Doppler. It's available abroad, but in my hospital we don't use it as well. The venous oxygen saturation, like I said, this one, we put it in the venous line, and it can tell quite fast because the venous saturation is the percent of oxygen that bond with the hemoglobin and return to the right side before it's then to the venous line, our venous line. And it's reflect amount of oxygen left over from the tissue removed tissue need. Normal systemic venous oxygen set is should be about 65 to 75. It means that oxygen extraction is about 25 to 35 too. But if the oxygen saturation is less than this, it means that it's extract more. Why it's extract more? Because maybe we delivery it less than it should be. So what we can do is we have to check the folate that we give to the patient. If we maybe sometimes we reduce the folate, or if we give proper folate already, we give a already high cardiac index, you have to check that maybe your hematocrit is high enough. Maybe during the rewarming period, they need higher hematocrit to carry higher higher oxygen in order to proper with the cell using. Inline bad gas will help to monitor the mixed venous oxygen saturation, and in the new version it show oxygen delivery as well. So you can see it even you don't need to calculate it. It help to make us monitor the patient posture. The one thing that is important for monitoring is the CO2 as well. CO2 in the arterial line bad gas. Normally we check every 30 minutes or 45 minutes, but in line bad gas it show you every 10 minutes. It will show you the CO2 as well. See how the CO2 is important. It show it's related with the cerebral autoregulation, because if the CO2 the CO2 value is in the normal range, it will maintain the cerebral vasodilation enough, and it's like but flow to the brain it's proper, it's good. But if the CO2 is very low, the sorry, if the CO2 is very low, it will result in cerebral vessel constrict, and it will make the blood go to the brain harder, or maybe brain perfusion is not it's worse than normal. Near infrared, as I said before, we use to monitor regional perfusion. In the baby, we used to monitor the brain perfusion. In adult, we use to monitor the brain perfusion in the case that we have to do the circulatory arrest, and we apply it to monitor the renal perfusion or splenic perfusion. This is called cerebral RSO2, and you have to know that the brain used the most oxygen than other organ in our body. So they said the cerebral RSO2 less than 56% within 48 hours, it's associated with the subsequent poor outcome. But you see the splenic RSO2 is would be 5% or 15% higher, because the splenic or maybe abdominal organ use oxygen less than the brain. Talk about the assist-based strategy. This is I will mention about the CO2. There are two strategies, which is the PS stat and alpha stat. The let me start with the 37 degrees Celsius first, as the PS 7.4 and 40 millimeter per curie of the CO2 first. And when we reduce the temperature to the 20 degrees Celsius, normally it will change the pH will be higher to maybe 7.5, and CO2 will be decreased to 25. Why? Because when we reduce the temperature, some CO2 will be dissolved in the solution, and the CO2 will left in the circuit lower. So if we want to keep the CO2 normal, it will show like maybe it's less respiratory unclosed. And if we want the CO2 normal, we have to reduce the FiO2. And sometimes if we in the baby, in the pediatric case, sometimes we turn on the FiO2 very less already. We have to add up the CO2, like put the CO2 to the circuit. But you have to monitor its cluster, like you have to use the inline bad gas, because if you measure every 30 or every 40 minutes, it might be maybe too long to monitor the CO2. It's not so good. They don't suggest that. And when we reduce the sweep gas, the pH will come back to normal, and the CO2 will be up to 40. In the opposite way, if we are rewarming the patient up to 37 degrees Celsius, the CO2 that already dissolved will come back to be gases, and the CO2 will back to be higher. It will show like maybe CO2 will be 50 and the pH will be more acidosis. But in this situation, we have to think about the error as well, because when we when we withdraw the bad gas and we measure the bad gas, maybe the pH will change all the time, and after we get the bad gas result, it might mean that the lab that we get, it might delay from the real situation. We have to think about that. And the bubble, and when we draw the bath to measure, maybe bubble will involve and will make it fall. Like maybe if a lot of bubble, it might show fall higher PaO2 too. During the rewarming, maybe the temperature is high. It might make the PaO2 high up faster than the lab what we get. CO2, as I mentioned before, that is related with the syllable auto-regulation. I will talk about this picture a little bit. It will show that if we use the PS stat, oh no, if we use the alpha stat, it means that we didn't collect the temp. The PS stat and alpha stat is different, which I mean, when we use, I don't know that you have learned about the PS stat and alpha stat much before, but for the alpha stat, is the bad gas strategy that we usually use in adult case, and it won't collect the percent of CO2 dissolved in the solution in each temperature that we reduce. So every temperature it will measure as the 37 degrees Celsius. So when we cool down the patient to like a 25 degrees Celsius, it still calculate as it is the 37. But the CO2 that we get, we might not correct. So maybe real CO2 will be quite low. And low CO2 is related with the cerebral vasoconstriction compared with when we use the PS stat. When we use the PS stat, because we collect the CO2 all the time when we cool the patient down. So we keep the cerebral vasodilation as normal. So many people, they said that PS stat in the baby help to like ben, it's help to do cerebral cooling and brain perfusion, but it's different in adults because the vessel in adult is not so clean. Maybe it's contained with some calcify. Some people use the PS stat in adult case, and it show a higher incidence of the stroke rate. So you have to know about that. This is the paper that study about usefulness of deep hypothermic circulatory arrest and regional cerebral function in the children. They separate into two groups. The one group that they do the deep hypothermic circulatory arrest alone, and the second group they do the deep hypothermic circulatory arrest, but they do the regional cerebral perfusion together. It shows that the group that you do the reciprocal cerebral perfusion for of 40 cc per kilo per min, or up a little bit above more than that, brain should be well protected against the hypoxia. And they said the RCP with enough folate is reliable to and be a safe technique for cerebral protection during the circulatory arrest in the children. Talk about the temperature management. This is the guideline from the Society of Thoracic Surgeon, Society of Anesthesiologists, and MSEC I think you know already about the AMSEC. It's like the Society of Perfusionists in the US. They launched the guideline of the temperature management during the cooling and rewarming period. Um, they suggest that the arterial temperature and venous temperature gradient should not over more than 10 degrees Celsius. This is the recommendation class 1. And the arterial temperature, it should be more than 37 because it is the temperature that surrogate the cerebral temperature. If we very warm, we flow with the too high temperature, it will harmful with the cerebral and kidney. During the warming, if the temperature is more than 30 degrees Celsius, the gradient should not be more than 4 degrees Celsius. And some center they said that they can use the like a nasopharyngeal represent as the core temperature, but I maybe it's really hard in our country because maybe they don't believe in it. Myocardial protection or the cardioplegia solution is a very big topic. So I talk about it just a little bit for let you know an idea that, okay, we will have two types now. Nowadays we will have two types of the cardioplegia solution. First one is the extracellular type and the second one is the intracellular type. The one that was like a popular using is the extracellular type, which is the one that have been using for really long time is the St. Thomas. St. Thomas contain with the crystalloid cardioplegia applied to use with the 4-1 cardioplegia, which we have to repeat it every 20 to 30 minutes. But this one is actually is was used for a long time, but it just popular in a few years ago. It's the single dose cardioplegia and just was successful use just in 2003. It's maybe 15, 17 years ago. It is the cardioplegia 1 and 4 ratio, but 1 part and 4 parts of the crystalloid. Expected arrest time is about 90 minutes, or in the original center they measure the myocardial temperature as well. If the myocardial temperature is higher than 15 degrees Celsius, they give the reperfusion dose. But if did not, it depends on the surgeon decision. Another single dose cardioplegia is custodial. Custodial is intracellular, which contain with low sodium and low calcium. Expected time arrest is about 2 to 3 hours, but in my hospital, they use only about 2. Except the doses that they use for preserve hearts for preserve donor heart for heart transplant. They use it like a larger volume is about maybe 2000 cc, but in routine case we use only about maybe 1500, and in the baby maybe we use about 30 to 50 cc per kilo. About the Del Nido cardioplegia, which is quite popular, famous nowadays. I would like to talk a little bit about the Del Nido because maybe in my hospital we're gonna use it in a few days. It showed that the paper showed that after using it, it's helped to reduce the rate of arrhythmia, and cardiac index is higher in the group of using the Del Nido cardiopedia. Mechanical ventilation ICU stay, hospital stay were significant lower. Lower troponin I release at the 24-hour interval too. Post-operative lactate level was significantly higher. This is maybe we have to monitor after using it after too. What we have to avoid use when we decide to use the Del Nido cardiopedia is about the hemodilution, because if you see it is the one blood and one part of blood and 4 parts of the crystalloid solution. So after giving it to the patient, it will be huge hemodilution as well. We have to think about how to manage the volume after delivery the cardiopedia. And the second one is a base solution that original used in Boston children. They use the plasma light, which is no calcium. But the solution we have, as I said in the slide before, that we have only acetate linker or lactate linker, which still have calcium. But someone said that it's not very important because the most important is about the lidocaine, and it's just the difference that we have to know. So we can discuss with the surgeon if something happened. The doses that the dose that they give for the baby, for the children, so many you will see so many cc range that they use. This is the survey from the US as well. So maybe I think it's quite the same in our country. We use about maybe 20 to 30 cc per kilo for the initial dose. But let you see that maybe some center they use 25, they use 40, they use maybe even more than 50. But I think it depends on discussion between perfusionist and surgeon. How do they believe, and maybe after using how the result is. And the temperature, it's vary from the 4 degrees Celsius to even 12 degrees Celsius. But this is, I think, is related with the maybe lower the metabolic rate of the heart. It's here to be careful to monitor it well. Almost done. About the perfusionist role, when the patient came to the OR, what we act as a perfusionist, we have to get the information from the patient, like how many kilo of the baby, how high of the baby. You calculate BSA, and you check the lab that the baby came with maybe how much hematocrit they have, what patient history, which what is the diagnosis, was the operation that they gonna get today. Because what I have teach you in the whole afternoon, it's will related with the diagnosis of the patient, and it's will related with the operation that the surgeon will perform. So we have to apply everything. We have to work as the teamwork. We have to know what the surgeon will operate for the patient, for our patient. We prepare the CPB circuit, we prepare the cannula, we prepare the accessory to proper with our case, because different case, maybe we prepare different. You have to know the diagnosis very well. You have to realize how, what's the surgery, that step of the surgery that we will do. Like maybe when you do the pathology of a lot, first thing, the surgeon, what the first surgeon will do, the second, the third, and maybe how it should be. This is the maybe the challenging of the paediatric CPB. We run the CPB, and at last we maybe tore off the circuit and send the patient to the ICU. This is the picture I show you, that in the real practice, the smallest baby, we use the EKG lead dot, that's the small one, to get it proper with the baby. We prepare the oxygenator proper side. If the baby is too small, we check the BSA. We calculate the flow rate that we want to use. We decide to choose which side of the oxygenator. The set that we use nowadays is the set that will be the compact set. Like maybe we can do the plumbing even we didn't connect the line to the table. When the surgeon start cannulation, they connect the arterial line with the aortic cannulation, with the aortic cannula, the air bubble, and they set up the position of the arterial line. This is the Norwood operation. In some case, we have to cannulate two aortic cannula. First one is the ascending, and the second one is the PA. And the venous will be left HVC as well. So we cannulate the 3 venous cannula as well. 2 aortic cannula, 3 venous cannula. It depends on the case. So that's why I usually tell you that you have to understand the diagnosis very well, and you have to understand the surgery, the operation. Venous cannula, this one. You have to know that how big of the venous, because you have, as I tell you before, the circuit venous line, it depends on the flow rate. If you fall higher, maybe your venous will be bigger, and you have to change the connector. You have to see the end of your cannula, how big it is, and make it matching with your connector. This one is our job we have to do. It's just something that maybe you don't need to use much knowledge, but it just what you have to be complain if you do something wrong. The persistent left HVC, we can connect in two style. Sometimes they will connect right SVC and left SVC together, and we put the IVC after. Some surgeon push the IVC and right SVC together and put the left SVC after. It depends. Cardiopedia. Sometimes we use the crystalloid cardiopedia. Sometimes we use the bud cardiopedia. We can mix and give it on the table, or we can mix in the cardiopedia set. But you have to think that with the small baby, maybe blood volume it will be so small, and the cardiopedia circuit, if it's not proper, it will be spend chart larger volume, and it will make more hemodilution. This is what we have to concern. This is the cardiopedia needle. You will see that in the small baby, like maybe 2-3 kilogram baby, everything will be so big. The cannula, the vein, venous, cardiopedia needle, aortic cannula, put all of them, it's maybe almost never have a space left to maybe to operate. It's not easy for even surgeon. It's difficult for everyone, I think. This is the just old picture. If you decide to do the modified ultrafiltration, you have to clear the air bubble really well in the hemoconcentrator. You see, folate is only maybe 500 cc. It's very small. This is the period that we didn't use the electronic gas bender as well. We still use the traditional one. So we try to make it set it very close to the table, but it stay low, so we avoid the contamination as well. And when we have done the CPB, we pick it, we throw away it, we take it out from the patient table. But if some cases still unstable, we try to keep it sterile in order to maybe go back to the CPB faster, and we don't need to use the new oxygenator, because we have to spend we have to pay for another oxygenator too. So just design depend on the situation in each case. The last one, after we send the baby to the ICU, you will see that a lot of thing it's on the baby chest, because everything seems to be big for the small baby, and we will send the baby back to the ICU with so many things on him. And you will see a lot of medicine. Maybe we go back, the baby is so small, but the equipment it's so many. Finally, I would like to say that as the starting slide, that the neonate is not small adult. Children are not small adult. We have to do it with we have to try to do it with it's like art. You have to try to adjust, to have to think about it in every single point. And with the baby, there are multiple perfusion techniques and the strategy for the children, for the neonate. The goal is to avoid the hemodilution because I think hemodilution is impact a lot for the small baby. Nowadays, PS that is still favorable in general, maybe not our country, because even me who do a lot of pediatric case, I still think that it's not easy because maybe I'm not sure. It's still quite I still quite hard because I still question something with using the PS that when we have to add up the CO2 because the baby has litten fall litten fall rate, but when we add up the CO2, maybe only 1 to 2% of the carbon dioxide, it will rise up the CO2 level maybe up to 7, which is quite hard to manage it. I think I have to still take time to learn about it. But in general, they said the PS that it's favorable in the neonate perfusion. The neonatal perfusion concepts are still evolving or developing. So maybe when I have chance to talk about the pediatric case, maybe in another 5 years, maybe something might be changed. Okay, we will done for the sections today. If someone have any question or don't understand what I teach, you can ask any question. อาจารย์อ่านยังอยู่ไหม
ยังอยู่ครับ
I'm done. Okay, and then before if someone want to ask a question before doing a quiz after, or maybe you can do quiz first and then you can ask me later. So someone would like to ask, just ask. Someone would like to do the test, just do the test.
I would like to ask one thing. Do we need to remember the cardioplegia dose for examination?
In routine case or
for examination,
like maybe baby 5 kilo, right?
Yes, Achan, something like that.
Okay. For the maybe bad cardioplegia, if the baby 5 kilo, we will give maybe 100 cc. It depends. If you use the bad cardioplegia set, you have to when you deliver the cardioplegia, you deliver the volume of the cardioplegia, and you have to make sure the pressure. If in the baby, like maybe when you transfuse the pressure, it's about maybe 120, and you deliver the cardioplegia until that baby get 100 cc, and then you stop. It's for like an induction dose. But if you use for the maintenance dose or reperfusion dose, you use only 10 cc per kilo. It means that second time you will give the cardioplegia only 50 cc, like 10 cc per kilo. In the this is what I mentioned about like St. Thomas. But if you use the custodial, the dose that we use is different from bad cardioplegia. But the Del Nido is bad cardioplegia as well. Even it is the different ratio, but the dose we give is the same, like a 20 cc per kilo, the same. but the custodial is will be different because maybe they suggest to use about 30 cc to 50 cc per kilo. That's it. Is it clear?
Yes, Ajahn. Thank you very much.
How about the question? I mean, my test. Oh, I think I forget to to to, to tell you. In the everyone take the course, the QR code as well. I would like to turn off.
Yes ค่ะ
You did you start?
Yes อาจารย์
Okay. I should have chance to see your face too. I would like to tell you that in the fetal or maybe newborn baby, the hematocrit is higher. I think I forgot to tell you. The baby has a higher hematocrit than adult, and in the gestation they have maybe about 18% of hemoglobin, and after delivery it still remain high and slowly decrease after, because as I said before, the baby has a higher metabolic rate. When they after delivery, you will see that the baby is bigger, faster than we are teenager, because they increase even the number of the cell and they increase the size of the cell too in every organ, in the heart, the lung, liver, or even muscle. So they consume a lot of oxygen. And the pH in the fetal circulation is quite more acidosis, because there is the mix, but the baby does not breathe themselves in the gestation, so they use mother bud to circulate in the circulation. The buds in the circulation of the fetal is the mixed buds, so pH is lower. I'm not sure, maybe 5.5. pH is 5.5, something like that. And the lung will fill with the water. So they said after deliver by how to say natural way, the lung will be squeezed and the water will be squeezed out of the alveoli, but it's still contained with some fluid in the alveoli. That make the baby has a higher heart rate and higher respiratory rate as well. The lung resistance still high, and it will decrease after. The lung resistance will be decreased to until it's related with the ventricle after 2 weeks. That means if we want to switch the left side to right side in the maybe TGA case, we have to switch before a couple weeks. And even some cases they operate after 2 weeks, but they have to mention about the ventricular thickness. If the ventricular thickness is still maybe similar, it might maybe get a good result. But if the ventricular thickness is quite low, pressure falling already, maybe after switch the left ventricle will be failure. maybe you have to give me a score too. How how understanding you get from my lecture. Maybe my English is not influenced as you guys. So
อาจารย์ค่ะ
what?
I already sent the score ค่ะ Have you got it
I'm not sure. Wait. Actually, normally it will show up on my notification, but I'm not sure why this time it does not show anything. Let me see. Maybe something wrong. Oh, okay. It still show you get the answer back.
ใช่ค่ะ Yes อาจารย์
Okay. So maybe it shows some on my. Maybe if you get the answer, it's okay already. I will check it later. Actually, I just want to check myself too if you understand my lecture very well or not. And
Achan, sorry for the interruption again. In the quiz, we have one question like why the platelet counts between adult and neonates are same,ครับ?
oh yeah,
Because the neonates are still developing, right? Like their organs are developing, so the platelet should also be developing, right? So the concentration should not be same between adult and
no. In the pediatric book, they said that the platelet number is quite similar in the adults. Even maybe the function is not, but I think the function is not the platelet function. But the cut how to say the about the coagulopathy, it will be still abnormal because coagulation factor is not platelet, like vitamin, like the clotting factor that related with vitamin K. But when it work with the stopping bleeding, it's work together, platelet as well and coagulation factor as well. But the number of platelet is quite similar in adult. They said that. Some more question?
why we cannot use blood priming solution in Fontaine's operation,ครับ?
Oh, sorry.
In Fontaine's operation, like why we cannot use?
Oh, no. Not it mean that blood pumping. We don't mean that we cannot use, but in normally we don't use because Fontaine operation the patient will came with high hematocrit already, because before doing the Fontaine operation they will come with the grain operation before. For you have to. This is what I want to tell you too, that you have, as I usually say, that you have to know about the abnormality really well, and you have to know about the surgery I mean, operation very well, because in each operation you can determine what will came with the patient, right? When the patient come to the OR to operate Fontan operation, you have to think the Fontan operation is the operation for making the patient has a single ventricle. So they will come with the gain operation before. The previous operation should be gain operation, or if not, they have to come with the single physiology. With the single ventricle physiology will come with the higher hematocrit. The children will come with the like a cyanotic heart. The hematocrit might high up to maybe 55% of the hematocrit. It means that when you see that the operation is the Fontan operation, you have to keep in your mind that okay, patient has to come with high hematocrit for sure. And if the hematocrit is lower, it's not too low for sure. And with the what I will example, like if the patient come with the AV canal or arterial switch, or maybe they come to operate Norwood operation, you have to know that those cases has to come with very small size of the baby, because it is the operation that has to hurry, has to operate early, because the baby cannot tolerate until they get old for sure. But for the tetralogy of Fallot or ASD or VSD, we will see the patient with maybe they're quite old, maybe 2-3 years old of the baby that come to operate with that operation. This is what you have to know first. I I explain.
Yes, Ajahn, quite clear.
Okay. Okay.
Thank you very much.
Good question. Maybe if I have a chance to give you a question for your final question, maybe you have to know the diagnosis first. Maybe my question will question you, like maybe I will bring up the some case, like maybe if the patient maybe 2, 3, 5, 4 kilo, and I let you choose the how to say, I will give you the choice for tubing, for the cannula, and you have to choose to make. You have to know that this baby has how much BSA, and you have to calculate your maximum flow rate, and you have to think about how big of the tubing size you will get. You have to think many things. It's just like maybe not recall question for sure. You have to apply your knowledge to use with the case, because what the recall question is so easy, maybe not cannot prove knowledge so much for recall question.
One more question, Achanya. In examination, will you give the interpretation table for the tubing size? Like 1/3 size, 3/8 size for interpretation?
Interpretation.
Like to interpret the table.
ให้เราลองพิจารณาว่าเราจะใช้แบบชูบิ้งแบบขนาดไหนอย่างเงี้ยครับ
Oh, is that not depend on the maybe the table? Is that not related with the patient table? It's related with the flow rate we use, because the flow rate we use will be we have to fit with how big of the tubing, because each side of the tubing, like small one 3/16, 1/4, 3/8, it will different in the diameter. The smallest one will have a higher resistance if we force so much, like maybe if it's allowed just only maybe 1.5 lit per minute, but we want higher flow rate than that. You have to change to use a bigger size of the tubing. It should be that way. Is that not related with maybe how far off the patient table and the heart lung machine? But it's depend on the flow rate that we want to use. But you have to know too that longer tubing, it will create a higher resistance as well. But when I decide to use which side of the patient tubing, I decide from the table guideline. It means that, okay, at least I have the reference that I won't put too small tubing with the maybe a high flow rate. Because if we use too small, it might create a higher resistance, and it will make the like it's trauma with blood element. It will make or create hemorrhage easier. It should be that way. I thought I will use longer than 3 hours, but just fit with 3 hours. Anything else?
Same time that you use for running the case, that quite complicated. Right.
No. Some cat is spent all day long. If you want to, maybe if you have question after, maybe in the future, you can text me via my Facebook Messenger too. Hope you guys has an eye opening about the world of the pediatric CPB. But I think maybe we still have a lot of many things to learn. It's like maybe knowledge is the long life journey. You have to study all the time, and something maybe not something. So many things we have to get to realize it in the future. Even maybe nowadays some issue is not clear yet, and we just follow like maybe, okay, so many people do this, and maybe do the same with them. It's good because we cannot prove yet which one is good. Like maybe about the PS stat, about the ACP in the baby, they try to figure if it's good for cognitive function or not, but it's really hard to explain that issue, because as we know, when the baby delivery, we don't know that how well of their cognitive function. They don't even talk, they don't even say anything, and we don't know that each baby has like a period situation the same. So we don't know that if we try to protect, okay, this baby we protect well because maybe they didn't smart at birth, or maybe someone so smart, and it's that not related with the four with the ACP we gave. So it's so many things have to explore, to learn more.
Any more questions ถามได้นะครับถามภาษาไทยก็ได้ถามเรื่องอื่นก็ได้
ใช่เด็กๆบอกว่าอ๋อ enough ค่ะ
พรุ่งนี้มีพรีเซนต์สัมมนาด้วยโอเค alright if you have no any more question just like would you mind if I ask for someone to say thank you to our guest speaker today okay
Thank you so much, Ajahn. We would like to thanks from all our heart, and we really appreciate with your beautiful and inspirational speech today. And we hope that in the future we have a chance to learn with you or to work with you again. And we wish you all the best, Ajahn. Have a nice day. Thank you.
Thank you. Hope you enjoy with my
okay that's it for today yeah
okay.
Of course, we did.
Have fun, enjoy, and get a good score when you have the test. I don't mean about my quiz. I mean about the quiz that the test that Dr. An will give it to you. It's Ajahn An. Okay.
okay thank you for being here today and thank you so much from my respect and my everything yeah so if we have a chance we will send our student to see you in the hospital maybe next time okay thank you so much Carl and have a good
Thank
day
you. Take care all.
ขอบ
bye
คุณมากๆค่ะ
Thank you.
ขอบคุณมากเลยค่ะอาจารย์
ขอบคุณค่ะอาจารย์
ขอบคุณมากค่ะ สวัสดีค่ะ
Bye.
ปิ๊บไปเลย